I was asked to say, tell people what was new, what was encouraging or exciting, and that's in the face of a situation which we haven't, to my knowledge, we haven't faced for certainly many years since the early introduction of imatinib, which is that we currently don't have, beyond imatinib and sunitinib, a clinical trial or an accessible new drug which we can offer patients who are progressing in that situation, which is a difficult situation for us. But that's not to say that there aren't interesting things going on and potentially good things in the pipeline. So I thought I would focus on both some of the exciting things that have happened in the last year, but also talk about some of the real nitty-gritty challenges ahead. Obviously, you all know about the results of the ACOSOG Z9001 adjuvant trial, which randomized patients between a year of imatinib and placebo, produced a highly significant progression-free survival advantage, which for patients with big tumours looked even bigger. But the curves come together and there hasn't been any survival advantage from that trial demonstrated. It wasn't expected that there would be, because as soon as the trial was unblinded, patients were allowed to cross over to adjuvant treatment if they wished. And 1 year of treatment was perhaps not going to be enough anyway to show a survival advantage. So a large trial has been conducted in Europe with more than 900 patients, which again randomized patients between no treatment and, in this case, 2 years of imatinib, and the results from that study are awaited. We genuinely don't know the answer. And in fact, because we're all living so long with the disease and the imatinib is so successful a drug, although that EORTC trial is powered to demonstrate a survival advantage, we're not going to know that for many years. So we're looking instead at the time to imatinib failure, which means that patients who've been on adjuvant imatinib who relapse, go on to imatinib again, and then ultimately progress. At that time, when they go on to a different drug, that's the time we're going to take, because if that is the same as it would have been if they'd never been given imatinib, if their tumour had never seen the drug, then there will be a survival advantage, because there will be a lead time, the time that the disease was under control while on adjuvant treatment, plus the time that it's under control when it comes back. If, on the other hand, that time on re-challenge, that time is shorter, then there won't be a survival advantage. And that's, at the moment, an unknown. However, at the same time, in Scandinavia and Germany, an adjuvant study has been going on, which, instead of comparing imatinib with nothing, compared 3 years of imatinib with 1 year of imatinib. And these were really bad patients. So these were patients with large tumours, possibly tumours that had ruptured, which we effectively say is metastatic disease, because rupture means the disease can go anywhere within the abdominal cavity. And initially, but only in the first year, I think, they also accepted patients with so-called R1 resection, which means microscopically positive. So patients who really actually still had tumour, just you couldn't see it. So this is a bad group of patients. Well, it was no surprise when Heike Jönsson presented the data at ASCO this year in Chicago, it was no surprise to see that the time to treatment failure, in other words, the time that disease progressed, was longer for 3 years compared with 1 year. That was no surprise at all. What has been a big surprise is that there's a survival advantage. So for the group having 3 years of treatment, at 5 years, 92%, whereas for the 12 months of treatment, 82%. So a 10% difference in 5 years survival for longer treatment with imatinib. And clearly that's something which we hadn't anticipated. We still don't know to what extent that is explained by the patients who effectively were being treated for active disease. The patients with R1 resection, the patients with tumour rupture, these are patients who actually did have disease, you just couldn't see it. Is that difference in survival explained by those patients, or is it just the fact that when patients with highly risky disease have an operation only, the likelihood is they're going to recur, we know that, but the time from recurrence to starting treatment is obviously then critical, because there seems to be a difference between starting treatment early, in other words, having the drug there, compared with treating patients when they overtly relapse. And that's something we don't fully understand yet, but this is obviously a very exciting development. So that's the conclusion. An improvement in relapse-free survival and overall survival for these very risky patients. And it was very well tolerated. So that's the plus side. So what about the key problem? The key problem remains the emergence of resistant mutations that make drugs like imatinib and sunitinib stop working. It's not the only thing. We know about other signalling pathways that can, as it were, take over from KIT. And there are also pharmacokinetic factors. And there have been lots of discussions about therapeutic drug monitoring and whether that should be done routinely and whether, to what extent, the ability of the drug to eliminate imatinib or sunitinib contributes to the drug stopping working. Well, we know, this is now 3 years old data from George Dimitri, who published the results from the initial American trial that compared 400 versus 600 imatinib. And they showed that patients in the lowest quarter for imatinib exposure had a much worse progression-free survival compared with the other groups. Now, we've since then...
This sounds a little low at the back.
Is it? Okay, all right. Since that time, we've also seen data emerging from South Korea, from Seoul, and also from France, from Bordeaux, where they've got a lab that's been doing monitoring for quite some time. The message is consistent, which is that patients with low clearance, well, high clearance, low levels, tend to progress earlier, but we don't still know what the target should be, because different labs, different groups of patients come up with a different figure, and it depends when the patient is tested, whether they've been on the drug for a month or a year. We found from our study that patients tended to get, as it were, the body gets better at eliminating the drug after a while. But nevertheless, I think we need further research, clearly. And it's not just imatinib. The same thing is true for sunitinib. These are data for sunitinib which show that the likelihood of a response increases with the mean plasma level. That's of course a real challenge for a drug where patients rarely tolerate the full dose of the drug, and certainly exceedingly rarely can the drug dose be escalated beyond 50 milligrams a day. Resistant mutations. We know that the likelihood of getting resistance increases the longer you're on a drug. So for patients with exon 11, the common mutation in KIT, who progress eventually and go on to sunitinib, in the randomized trial that led to the registration of sunitinib, 3/4 of patients had developed secondary mutations, and that's why they progressed. Whereas if they'd got an exon 9 mutation, which was intrinsically resistant to imatinib, only a fifth of them had a secondary mutation. They didn't need a secondary mutation because the disease was already progressing on the drug. Whereas patients with no primary mutations in KIT or PDGFRA, they didn't have secondary mutations, again, because they weren't responsive in the first instance to imatinib. So the driver depends on the drug. We've learnt a lot about how these drugs bind to the protein. I'm not going to blind you with science, but just to say that there's what we call an activation loop, and there's an active and an inhibited form, and imatinib binds to this inhibited form with the activation loop in, or out, sorry. Out, in. Looks out, but it's in. Or the other way around. Anyway, I have to believe that. The implication of that is that imatinib and sunitinib both bind to this stably inactive formation and keep it inactive. Whereas other drugs, like sorafenib, can inhibit when there are mutations in the activation loop, which alter the conformation of the protein in such a way that imatinib and sunitinib don't work. But it's simplistic to think that GIST is just one disease. It's every time you get delving into the biology of a cancer, you discover that one disease is actually 6 or 10 or 20 in terms of how they function biologically. And that's just as true for GIST, because some exon 11 mutations, which we think, okay, that means it'll respond to imatinib, some of them don't respond so well. And we know that certain particular types in the downstream end of the mutations in the downstream end of the gene, the progression-free survival is worse because the ability of imatinib to inhibit these particular tumours is not so good. So clearly we need new drugs. Regorafenib was recently tested in a big randomised trial, the GRID study. This is a Bayer compound, an analogue of sorafenib. It was a randomised trial, placebo-controlled. We don't have data. The trial opened and closed so quickly that we only managed to get a couple of patients in the trial. But one of those patients has progressed and switched from placebo to active drug, and early indications are that it may be helping.